Hello, this is a lecture over chest radiography. Towards the end, we're going to be seeing chest radiography applied to the hospital setting. This is a chest x-ray. This image is outlined so we can see the relationship of certain anatomy in the chest. Starting with the right side of the chest, we have the right apices here. Coming down, we have the manubrium, which is the superior part to the sternum. You can see the outline here. This is a superior vena cava, this structure right here. It's outlined for us. It's a soft tissue, so it's going to be a little difficult to see on an actual chest x-ray. But this is the position where it would be in. The right main bronchus is part of the bifurcation of the trachea. The trachea comes down here on the midline and it bifurcates into the right main bronchus. The horizontal fissure separates this lobe of the lung with this lobe of the lung. This is the right atrium of the heart. Oblique fissure, again, separates this lobe of the lung with this lobe of the lung. The inferior vena cava would be here. The diaphragm / liver. The diaphragm is this structure here, separating the lung with the starting at the top part of the abdomen. The liver would be sitting right underneath the liver, the diaphragm here. So this is where the liver would be. Going to the left side, we have the left apices up here. Coming down, aortic arch. Again, it's another soft structure, so it's a little difficult to see on a chest x-ray. You still will be able to see it, and this is where it would be. The pulmonary trunk, which is delivering blood to the lungs to get oxygenated. The left main bronchus, which is the other bifurcation to the trachea, so it bifurcates to the left main bronchus. The left atrium of the heart. We have the left ventricle of the heart here, which is pumping blood back up through the aortic arch to the rest of the body. Oblique fissure separates this lobe of the lung with this lobe of the lung. Again, the diaphragm. Then we have the left cosophrenic angle here. The right cosophrenic angle would be here. Looking at the lungs in a little bit more detail, the right lung, again, has 3 lobes: the superior lobe, the middle lobe, and the inferior lobe, and it's separated by 2 fissures. This is the horizontal fissure and the oblique fissure. On the left lung, we only have 2 lobes, which is the superior and inferior, separated by the oblique fissure. Size comparison, the right lung is a little larger than the left. This is due to the heart being more on the left side, taking up space of the lung. This is why the left lung is slightly smaller. Before we can take a chest x-ray, it is important that the patient is properly prepped. By this I mean we're going to remove the patient's clothing from the waist up, and we're going to put a gown on. We're going to remove the shirt. We just want to make sure there's nothing in the shirt that can cause artifact on the images. So males have them remove shirt, place a gown. Females, they have bras, so we want to make sure the bras are removed. We're going to remove any jewelry that can be superimposed over the chest. Sometimes patients are wearing necklaces and the metal will show on the x-ray, possibly obscuring some pathology that can be behind there. So we're going to remove that jewelry. And then we're going to explain the exam in simple text to the patient and allow for any questions. By this I mean a lot of times we want to get fancy and tell them, speak in medical terminology to the patient, and it's difficult sometimes for them to understand. So if you explain the exam in simple terms, they will understand, they will know what's expected of them, and you will have a good study. You want to have an open conversation and allow for any questions they might have. I think this is a pretty funny diagram here. So for the PA chest x-ray, this is going to be the criteria we're going to be using. We're going to be using a 14-inch by 17-inch cassette. We're going to place the cassette lengthwise or crosswise in the bucky here. We're going to be at a 72-inch SID, so the distance from the x-ray tube here to the bucky should be 72 inches. The patient is standing with the chest against the wall bucky, as you can see. This patient is here. The mid-coronal plane will be perpendicular to the image receptor. So we want no rotation. The patient should be straightforward, not rotating any. We're going to rotate the shoulders forward. When we do this, the scapula moves laterally out of the lung field. Central ray is going to be at T7, right here. We're going to have a little bit of light above the shoulders. We're going to have about 1.5 to 2 inches above the shoulders. We're going to be placing a left marker on the left side of the patient. So we see a marker here, and we're going to place it on the left side of the patient. That one, very important. We're going to protect each patient with a lead shielding. This patient's wearing a wraparound shield, which is placed directly on them. This is another example of the lead shielding that can be placed on this rolling pole here, and you can place it directly behind the patient. Lateral chest x-ray. We're going to be using a 14-inch by 17-inch cassette. We're going to be placing the cassette lengthwise in the bucky. We're still going to be at a 72-inch SID. The patient is standing with the left side against the wall bucky. This is because of the heart. If we were doing a right lateral chest, the heart will be magnified and demonstrating that the patient has an enlarged heart, which in reality they don't. So we want to reduce magnification, so we're using the left side of the patient's body here. We're going to bring both arms above the patient's head so they won't be in the way of the chest. The mid-sagittal plane is going to be perpendicular with no rotation. We don't want the patient rotating any. We want them straight. The central array is going to be at T7, just like the PHS X-ray. Then we're going to be placing the left marker at the superior and anterior part to the patient. So it would go here. And here they're using a rolling pole with a lead shield on it to protect the patient. So we've protected the patient. We're about to make the exposure. We go back to our control booth. We're going to select an appropriate technique. I won't go into techniques because it can vary a little bit with type of machine you're using, the company, if you're using digital. So that won't be covered here. Before making the exposure, we're going to have some breathing instructions. The patient is going to take in a deep breath. They're going to blow that air out. Then they're going to hold their breath on the second inspiration. This will really expand the lungs and make sure we have a really good image of the chest. And this is the method we use for chest radiography. And again, with any x-ray, we're using radiation, so we need to keep this in mind. This is an acronym. It says ALAR. It stands for as low as reasonably achievable. This means we're using the least amount of dose that we can use without interrupting the diagnostic quality of the image. So as low as a technique you can use without overexposing the patient and still getting a good image. Okay, so you've taken your chest x-ray, you did everything, you followed all these steps. Now we're going to evaluate the film and make sure that we got everything we need to submit it to the radiologist. On a PHS x-ray, you're going to look for the entire lungs from the apices down to the costophrenic angles. You don't want to clip anything. There's no rotation in the chest. The sternal ends of the clavicles are equidistant to the spine, showing there's no rotation. You'll be able to see 10 posterior ribs visible above the diaphragm if there's good inspiration. This is what you want to look for. And the scapula are projected outside of the lung fields. That's, again, why we're rotating the shoulders forward. On a lateral, we're going to be seeing superimposition of the ribs posterior to the vertebral column. So that demonstrates that the patient is properly positioned with no rotation. The arms or its soft tissue are not overlapping the lung field. This is why we bring the arms over the head. We're going to see a view of the sternum in the lateral position with no rotation. And we're going to be, you want to make sure you have the apices to the costophrenic angles shown here. So this is an example of a good PHS x-ray and a bad chest x-ray. On the good one, you can see that there is no rotation. The clavicles are equidistant to the vertebral column. The scapula is out of the way of the lung field. You can count 10 posterior ribs here, and the film is marked. We can see from the apices down to the costophrenic angles. Over here, this is a bad example of a chest x-ray. This image has clipped, shows some apices have been clipped. There's no marker here. The scapula is in the way of the lungs. It's not an image you would want to submit to a radiologist. Again, this is a lateral view. This is what you want to see. This is, you have some superimposition of the ribs here. There's no rotation. We have the entire lung field from the apices down to the cosophrenic angles. The patient's arms are above the head. They're not obscuring the anatomy here, and the film is marked. This is a bad example. You have some rotation along the ribs here. The arms are in the way. You can see the soft tissue here. They're not raised above the head. There's no marker to demonstrate what side this is, and the front part of the chest here is clipped. So sometimes you're going to have a patient that cannot stand, they can't walk, so we have to work around that. We have to get images still and work in the current patient situation, and we're going to see this every day in a hospital where the patient can't get up. We're going to work with them to get an x-ray. So this is going to be an AP chest x-ray. The patient is high in bed, not down by the feet. This is, if they're in the stretcher here, you want to make sure the patient's sitting up high, and so the lungs can properly expand once they're sitting up high and they're breathing in. You want to sit the patient straight upright, like here, or lie the patient supine, like here. We're going to place the x-ray cassette directly behind the patient. Here's a cassette. Here's a cassette. The central ray is still at T7. Since we're now positioning in the AP position, you can use a jugular notch to find T7, which is T7 is approximately 3 inches to 4 inches below the jugular notch. So if you can palpate the jugular notch 3 to 4 inches below, that's approximate to where the T7 would be. Again, we want to collimate properly and mark our film, and we want to make sure the patient is protected with lead. This is a lateral stretcher chest x-ray. So again, the patient cannot stand. We're going to be performing a lateral chest x-ray on the stretcher. We're going to assure that the patient is high in bed and sitting upright. So you see here, we're going to place the patient's left side against the wall bucky. So this patient's left side is against this wall bucky here. We're going to be placing a radiolucent sponge behind the patient. This is to ensure the patient is sitting upright. If the sponge was not here, the patient's back would be up against the stretcher here, with possibility of getting some metal of the stretcher on the film, which you don't want. So you want to make sure you're using a radiolucent sponge here. And we're going to place the patient's arms above their head, holding above their head or supporting, and holding some supporting handles here, so their arms won't be in the way of the lungs. And again, we're going to mark the film and place a lead shield. So that is it. I hope you guys have learned something, and you can apply it to your clinical rotations, and the more you practice, the better you're going to get. So thank you.